All right, you guys ready to learn a little bit? It's time to do a little bit of surgery. All right, so we stabilize him a little bit, Dr. Julie. All right, are we ready to go to surgery?
We're ready.
Okay. It's time to learn a little bit about basic abdominal exploratory guidelines with Dr. Shadi Arifaj and Dr. Justin Ganjei. We're gonna blow the roof off right now, so let's give a huge, big round of applause. Keep it going, keep it going, keep it going. Don't stop, can't stop, don't stop. Yes. There we are. Okay, do we have everything we need? Are we ready to go? Are we ready?
Yeah.
Oh, no? Okay.
Hello.
Yeah, because I'm not getting this.
No.
Yeah.
I don't think you're on.
You
Turn
want?
me on, please.
Yes. TJ, turn me on.
Turn this guy on.
There we go.
I don't know.
Okay.
That's your subtle way of saying they don't want to hear you.
It'll still work. The point will still work. This can't just slide. Okay, thanks everybody. So Justin and I will go into some basic abdominal exploratory guidelines. Next slide. Whenever you're ready. This list of guidelines we're going to go over, of course, is not an all-inclusive list. And you can see we're going to go over all these different bullet points here, and this does not accompany all of surgery. We went through years of training to figure out the finer points of it. This talk was basically an idea brought about from observing general practitioners who are trying to perform surgery on their own or want to get into surgery and ways of sort of improving the process. Next slide. So a little bit about me. I went to Cornell University, graduated in 2006, one-year internship at Angel, did 2 surgery internships at Long Island veterinary specialist, then my residency, flew out west to left New York, worked as a specialist at Las Vegas Specialty Hospital. From there, I operated 3 facilities in the Silicon Valley area. I was on call 24/7 for that year. Then from there, I became part owner of a hospital in LA, and now I run vet triage full time. Next slide.
And so I went to Virginia Tech, and then I came back here. I'm from here originally, and stayed in Gaithersburg in my rotating internship at VRA, went to BSC Indiana, did my internship and residency there, stayed there for a couple of years. I just left there and went back to VRA, where I'm now heading the minimally invasive surgery and IR department, and I'm also adjunct professor at Virginia Tech for soft tissue surgery. There's an uncommon picture of me in a scope in a dog's skull, I think.
Next slide. So just basic definitions, you pretty much use laparotomy, ciliotomy, and abdominal exploratory as synonyms. One other way you can characterize what procedure you're doing is, of course, based on the approach. We're going to stick to ventral midline abdominal approaches, obviously, for this discussion, but just be aware of all the different approaches that are possible depending on the case. Next slide, please.
So, I mean, there's a lot of things that you get involved when you're in surgery, and a lot of times you're not going to have the luxury of having an anesthesiologist or a criticalist with you during there, so you're doing a lot of it yourself, depending on where you're at. So, when you're doing it, there are things to be cognizant of outside of the surgery itself, such as the sterilization protocols your hospital is using, antimicrobial usage and proper use and appropriate usage, the anesthetic protocols a lot of times you're going to be managing as a surgeon. Operating room traffic is something that can get way out of hand that you have to kind of be aware of. Looking at instrument packs, really important to have what you need to do what you're going to take on and know what's in there and what you don't have. Gowns, gloves, what kind of anesthetic monitoring equipment do you have, and also, I think sometimes it gets lost in just the surgery, but the post-operative recovery that you're going to have to deal with too, and what kind of surgical procedures you guys are doing.
So we're going to assume that these are self-evident to folks here, basic principles. Next slide, please. So what are the indications, broadly speaking, of abdominal exploratory surgeries? We pretty much divide into 3 broad categories. You're either exploring the abdomen for a diagnostic reason, so biopsy collection for a case that has chronic gastrointestinal signs and you can't figure out what's going on. You want to confirm a diagnosis, so that's the way to find a foreign body in the gastrointestinal tract is abdominal explore and find it. Of course, it can be prophylactic as well. Incisional gastropexy is prophylactic, gastropexy rather is a preventative measure, and therapeutic, of course, enterotomies, splenectomies, etc. And obviously, these categories are going to overlap, right? So you may go into the procedure, not sure if you're finding a foreign body, you find it, there's your diagnostic approach, and then of course now therapeutic, you're going to fix that pet. And so you think about abdominal exploratory towards these 3 broad categories, but of course they can overlap. Next slide, please.
So a really, really important thing when you're doing any kind of surgery is to be systematic. Make a system, just kind of like your physical exam, your surgical explore of the abdomen should have a very consistent and thorough kind of order to it. So make sure you look at your medical record. I don't know how some people operate where they just have drop-offs for surgery. They've never seen the patient before. You gotta look at that record and see what you're doing. Make sure you don't cut off the wrong tumor. I've seen it happen a million times. Or wrong leg. You don't want to do that. So go through that medical record. Make sure you know what you're doing. Make sure you're, I would always do, if you didn't see that patient, do your own physical exam on that patient and make sure that, you're agreeing with these diagnoses. If there's any add-on surgeries that clients are going to do, just be aware of what they are. Is it going to increase the mortality or morbidity to what you're doing? Should you be doing that? Do you really do a dental while you're taking out a splenic mass and a liver tumor? Probably not, even though the client wants it. Do these patients need feeding tubes afterwards? It's a really sick, septic patient. Just doing surgery might not be all you gotta do. So be aware of, feeding tube options that might be beneficial for this. Dermal mass excisions, again, if you're doing a big major abdominal surgery and the owner wants 25 lipomas cut off at the same time, maybe take off like one near your incision and not the rest of them, So just remind yourself what's the goal. We can be really easily talked in or pushed to do things that the client wants if it's cheaper. Just do what's right for the patient and for your comfort level too. So biopsies that you're gonna get, make it based on what your preoperative diagnostics indicate to do. Elevated liver values, obviously get some liver. And then think of like if you're taking out tumors, where are organs or skin tumors, where are they gonna metastasize to? What are you staging? You take those out to sample that for that. Client communication, super, super important. I think especially how busy it is nowadays, things can get lost and you get rushed into doing things. You want to make sure the client knows exactly what you're doing and you're documenting it. Pre and post-op, make sure you really, really tell them what happened. And if there's complications, you got to be crystal clear with them about that because complications will happen and things will deviate from the original plan. So be clear in your communication with them, document it, and again, prioritize your procedures that you're doing based on stability. You may not have the ability to do everything they want to do if the patient's not doing well.
Yeah, I tell all the clients preoperatively, okay, we're going to try to aim for these procedures, but I'm going to prioritize them, and I have full control over abandoning any procedure that I want during the procedure. At the same time, when you're doing the postoperative call for that neuter, and they're like, oh, how'd that mass removal go? And you're like, oops, I forgot, right? Patient was stable, you could have done it. You didn't look at the record, you didn't recall the client communications beforehand, so it could work the other way as well.
Yeah.
Next slide. So this slide is really focused on reminding everybody to, when you perform your abdominal exploratory, the same way you review radiographs or perform your physical examination, you want to be consistent and thorough. Whatever your methodology is, whether you're going to start from the cranial aspect of the abdomen, walk down the left gutter, caudal, then right gutter, and then deeper tissues, great. Or reverse, or whatever organ, whatever system you're trying to implement for your abdominal explorers, just be consistent. This is how you miss stuff. If you're not consistent with your exploratories, then you're going to end up missing areas of the body. The abdomen can be a very complex place, especially if there's disease. So this is just a reminder to be systematic in the way you approach abdominal exploratories. Next slide.
So gauze is extremely helpful. Lap sponges, really, really helpful, but also can be a huge problem if you don't keep track of it. So when you're using these things, I think how many of you guys have gauze automatically in your packs when you're doing surgery? How many of you can count that gauze before you go in? Not a lot of hands go back up. How about counting after you're done? All right, and how many of you just throw them into a trash can sometimes out of frustration for blowing gauze? I do sometimes, and it's bad. So be, aware of that, how many gauze you have in there, and don't trust the packs, because I pulled out one supposed to be 10, I found 9, and you spend an hour trying to look around, and there's only 9 in there at the beginning. So count your gauze, have an assistant count it, and then put it somewhere where you can see it. Don't throw it in a trash can. Throw it on a blue towel on the floor or something so that somebody else can count that at the end. It's the most frustrating thing when you just finish closing up the abdomen and then you're like, wait a minute, there's only 8 sponges here. And sometimes you can swear it's not in there, but it's in the abdomen. And these gauzy pagomas, we see them. So the pictures on here of what they look like, they can be a huge nightmare and legal issues for you later. So count your gauze before you make your incision, count your gauze at the end before you're done. Same thing with lap sponges. It may sound kind of ridiculous because it's a lap sponge and you're not going to leave it in there, but as Shadi probably also may have seen a lot of things in abdomens, like instruments, lap sponges, so it happens in people too. So just count that, take away all these variables so you don't have to worry about this stuff. And always, I think it's super important, to use radiographic like indicators on your gauze. They make the ones without it. I mean, that's fine, it's cheaper, but if there's any concern, you can always snap a radiograph and tell. And if you see that strip there, you know 100%. And I say that also for when you're packing the back of the throat. People try to just put a piece of gauze in there real quick for doing an oral surgery. And I've watched patients swallow that gauze when they're waking up too quickly. And then, if you didn't see that, and you're missing the gauze, you have a foreign body there that you may not know about. So I always, same thing for rectal surgery. Like when I use gauze to pack the rectum, I make sure it's radiopaque because you wouldn't think it can happen, but they can suck things up there pretty good. And you want to just be able to track that. So radiopaque strips are really, really, really important to do that. So cover your ass.
Next slide. Skin contact is a common issue that I see if I'm observing in terms of resident performed surgery or GPs. We get so focused on the procedure itself that we forget about self-contamination. So bringing those dermal bacteria into the incision, that's a preventable issue. So if you look at the picture there with the surgeon performing surgery on the cat, I mean, what's that watch for? Why are we wearing a watch during the procedure? There's no need for that. Get rid of it. It's a source of contamination. The gloves are starting to roll up on the wrist, and of course there's no gown there as well. And at some point, the procedure is long enough, your arms get fatigued, you're going to touch the sterile area with your wrist. So what are we doing there? And of course there's many other things wrong, right? There's no heating supply on that patient, they're on a cold table. Look at the instruments, they're flowing over the sterile drape. So, it's a great picture to show lots of things that are wrong, but we forget about it. And we all do this, where it's a quick procedure, just, whatever. Well, if it was you undergoing the knife, what would you want your surgeon to do? So you want to try and maximize being as maintaining some technique as possible. So be aware of your wrists, hands, and fingers. You want to use your surgical instruments. So the picture with the needle holders there, the needle, we always end up taking the needle with our hands and putting them in the needle holder. Let's try and use our instruments. That's what they're there for. It minimizes contamination that way. And make use of your needle points. You can actually pick up the portion of the side of the abdominal wall with your needle holders, or with your needle rather, and then start suturing that way too. It works really well. Or just use gauze if you're really trying to touch the skin, you want to manipulate it for whatever reason. Use gauze then, and at least that way you minimize contacting the skin with your gloves, and then you can throw away that gauze afterwards. Next slide.
I mean, this is a really great point. Can you go back to that slide for a second? Because you made a lot of really great. This is a great slide with these pictures. Because I can guarantee you that suture is going to touch all over that table with how long the suture lines are. So and his wrist. So I think that we take sometimes for advantage, like, well, we'll just put some antibiotics on it, we'll be fine. It's a really, really bad mentality to have, to just be using lack of sterility or aseptic technique to just cover it with antibiotics. So I think this is a great point.
And actually, look the picture at the bottom with the medicine bombs, using it to open I presume it's the linea alba. You see there's a bloody gauze there. So right there. I mean, that gauze is just waiting to fall in the abdomen, unbeknownst to the surgeon, right? And you see they use it, it's got blood on it. So you use it and throw it out. Don't keep it on the table. It's just waiting to fall in there, and you'll never know. And it can be just a routine spay. And now you went from a routine spay to this disaster when a week later the patient's coming in with ascites and vomiting, and you find out, there's a gauze in there for a simple procedure that you've done 1,000 times. Next slide.
We have lots of instruments to our availability, and you should really use them basically to your hands, like Edward Scissorhands, Edward Surgery hands. They are an extension of you, and they should be used properly. We all got taught that way in school to do it. So just kind of use them the way they're supposed to be used. I'm guilty sometimes too of using sometimes I'm in a hurry, I'll use a mosquito to suture things, and it's probably better to use needle drivers for that. So just be cognizant of where you're doing. Try to get familiar. Everybody here is probably very seasoned with using surgical instruments, but just make sure that also if you have new people coming in that are doing surgery that are just out of school, they might not be comfortable holding these instruments or using them. Make sure they're using them appropriately. Also because they can damage them, and that's more cost to you guys in the future to have to get new instruments, especially if your favorite needle drivers get broken or sprung. And if you have really sprung instruments, just get new ones. It may be a little bit more cost then, but it's going to be a lot more comfortable for you to do surgery when you have needle drivers that you actually like and work appropriately rather than having it pop off your needle every single time. So, just be cognizant what you're doing. They taught us all in vet school, don't grab the skin, don't push on, don't squeeze things. I'm guilty every once in a while, everyone does it, but try not to. There's a reason they taught us those things. So, be cognizant how much pressure you're doing, especially in like stressful scenarios, for how much you're really squeezing on things, and use the right instrument for the right task. You don't want to be using rat tooth forceps for GI surgery, unless you want to put more holes in there or devitalize your tissue. Make sure you have a pair of babies in your soft tissue pack. Like, that's just very appropriate. And I think this is also a good thing when you're doing kind of GI or surgical oncology to kind of practice the technique of having clean instruments and dirty instruments. Clean and contaminated, don't use the two interchangeably, just to avoid infection rates and all that. So make sure your instruments are in good quality and control. Make sure they're being cleaned appropriately. How many of you guys have seen the pair of instruments where you're about to do surgery with a big blood stain on it that went through the autoclave? It's a sterile blood stain, but it's disgusting, and I wouldn't want that in my body. So just make sure that your staff is cleaning them appropriately, and always check your indicators too to make sure that it actually passed. Just all little things that sometimes get lost that can kind of affect your outcome.
Next slide. And so just to be clear here, it's a bunch of rules that we're throwing out at you. Folks that perform surgery know all this already, but just a good refresher on being cognizant of what you're doing, where all your instruments are, your gauze, your hands, your wrists, just being aware of it. It'll really help with infection rates and complications. So this is just an example of what would be included in a general soft tissue pack. And of course, there's a picture there of a suction unit as well as cautery, kind of basic instruments that you're going to use if you're performing soft tissue surgeries. Just to give you an idea, the one aspect of this that I want to mention with the Balfour retractors, the amount of veterinarians that I know that are afraid of performing spays in large breed dogs is profound. And from what I can tell, it's mostly just poor visualization. They don't maximize use of an assistant in surgery who can help with keeping the abdominal cavity open or pushing organs aside so you can get to that ovarian pedicle, or just use self-retraining Balfour retractors. It's so worth it, especially when performing abdominal procedures, whether it's a spay or actual exploratories. Balfours are fantastic. They will just save you so much frustration, and they also will increase your confidence in performing surgery in large breed dogs. So it is certainly worth the investment. And you can buy different size Balfour retractors, of course, but it's the bigger dogs that folks tend to be worried about with procedures like spays. Next slide.
One thing that is really easy to forget, probably more than anything, is your posture during surgery, which doesn't really seem like a big deal like at that moment in time, but it will wear you down over time. And I'm 100% guilty of this, and actually, my staff, I have to thank them, because they're the ones that kind of look at me and they're like, what are you doing? Why are you down here? So make sure that you have the table height set to what's comfortable, especially if you're going to be doing a long, procedure. You want to kind of be comfortable, so, just make sure you're good with it. Make sure your staff knows too. They're really good, sometimes just looking at you, and if they see you hunched over or you're up here too tall, it's going to ruin you. When I went to study for boards after sitting for 12 weeks after studying for surgery, I was a mess. And I had to go to a chiropractor for a long time to help me out. So I think this was part of it. So make sure you have a straight back, get your legs, you can widen your legs a little bit to lower your height, don't bend. Try not to, put your neck down like this. Surgical floor mats are really helpful. Do you guys have support for your feet anywhere? How many people have them here? A lot? Not really? No. If you're doing a lot of surgery, you really need it. It takes a lot off of you. And so, you can stand up on little stools if you need to, if you're with someone who's taller and you're assisting them. And then, just again, kind of get your elbows to about 90 degrees. This is kind of that posture that you want, just to make it more comfortable for yourself.
Next slide. So with suction, I do find a lot of practices do not have suction capabilities, even though they're performing procedures like spays. And so if you are able to have suction, if you're going to use it, or if you're performing surgery to begin with, then it's a useful item to have. So typically the rule is you're going to try to lavage the abdomen until the fluid is clear. Obviously this is depending on the case. You're not going to be performing abdominal lavage on your routine spay. We're talking about a procedure where there's contamination or there's a visceral rupture prior to going in, things like that. So you want to lavage the abdomen until the fluid is clear. You want to make sure you have warm lavage. So typically we have it in some sort of incubator unit, so it's already warm for you if you do this a lot. You want to balance lavaging with the patient's stability. So yeah, it's ideal in a hemoabdomen, especially if it's a ruptured splenic mass where you're really concerned about neoplasia. It'd be great to lavage the abdomen and remove any potential exfoliated neoplastic cells. But if the patient is already critical and not doing that great under anesthesia, you want them off the table. So I'll skip the lavage and get the patient off the table. Just perform the splenectomy, get your liver biopsy, and get out. So you have to balance it with patient stability. Obviously, with a septic abdomen, if there's a perforated foreign body, you want to lavage all that material out. And if the patient's unstable, you've got to hustle if you're going to do this. There's no point in having a clean abdomen if the patient is deceased, right? So you have to prioritize these things. I actually will wipe the edges of the abdominal walls, and then once I close the linea, I'll wipe the incision itself. So I'll take a single gauze, a little bit of sterile saline, and then wipe one edge of the abdominal wall, throw that gauze out, do it again for the opposite wall, and then when I close the linea, then that surface area, I'll take one gauze, sterile saline, wipe it, throw it away, and that's really just to protect against whatever occurred in that abdomen, as well as any sort of mistakes that I did by touching the skin with my gloves, because there's going to be cross-contamination. I'm going to contact everything, and so I actually will lavage the layers. This actually, what I find it really useful are like megacolon cats for doing a subtotal colectomy. I mean, the steatitis in those cats is crazy, and so I do find that besides debriding the subcutaneous fat from those cats, a lot of them end up being fat cats. I also do lavage, and I think it markedly helps them.
I totally agree with that. Just yesterday I did a subtotal colectomy, and I was talking to my intern about how important it is to lavage, because cats, they love. How many of you have had a horrible steatitis case? I have, and it's cats. They do this all the time. So really, I think it's a great idea especially for contaminated things, GI surgery. Wash that sub-Q.
Yeah, I'll have cats that just unravel their entire closure. And they'll just come in like the next day with just a massive abdominal hernia, and and then you go back in there to reoperate, and just the fat is inflamed, and it just hydrolyzed that suture that was supposed to stay in there until healing occurred. So these are just helpful hints. Next slide.
Esophageal tube usage is pretty important. I think that the esophagus gets missed a lot in evaluation. It's kind of a hard thing to evaluate, but make sure that if there is any concern that you're evaluating it. There's a couple ways you can do it. Passing an orogastric tube is a really easy way to make sure there's no foreign material in the esophagus, especially if you're dealing with a big linear component or an esophageal foreign body potentially. I pass esophageal tubes a lot for emptying out the stomach if they're really, really obstructive, those proximal duodenal obstructions that are like massively dilated and fluid filled. Honestly, right after they get intubated, I pass this because cats especially will love the projectile vomit as soon as you knock them out. And I think passing this tube in there and just emptying that stomach out before they go down is a really, really, really nice way to avoid aspiration pneumonia, esophagitis, and nasopharyngeal stenosis and all that. So it's also nice when you're in the abdomen, you see a stomach like that, or for like a GDV, you can't see anything. If you get that stomach tube in there and decompress it, it makes your job a lot easier. It makes rotating it or detorsing it a lot easier too. So these are really, really handy to have, and I think should be kind of there any time you're doing GI surgery, should be at least available to use these things for. And then just remember when you're doing it to kink it before you pull it, so you don't pull that fluid up into the esophagus.
How many folks here have orogastric tubes in their practice? Yeah. How many folks here place nasogastric tubes for enteral feeding post-op? And so, I imagine you find yourself in a scenario where you've got the dog under anesthesia and you're in your radiology unit and you're trying to pass the tube and it's getting annoying. Does that happen to folks? That's something that's a common experience. So what I found out, and let me know if you do this as well, what I'll do is if I know I'm planning on placing a nasogastric tube post-operatively, then while I'm doing my explore and whatever else, my technician is first going to actually pass the nasogastric tube, and then in the pharyngeal region, they will grab the nasogastric tube, and then I'll have them suture the tip of the nasogastric tube to this hole that's at the distal end of the orogastric tube, and then pass the orogastric tube. So if I'm in the stomach anyway for, let's say, gastrotomy or something, I won't close my gastrotomy. Once they pass the orogastric tube, I'll grab it, I'll take out the suture obviously, and then hold on to the nasogastric tube, and they'll pull the orogastric tube out slowly. Now I have an NG tube in place. I know where it is, I know it's in there, it didn't kink up in the back of the throat, there's no frustration afterwards, and this is all done in a patient that's stable and can handle this. So it saves a lot of time. Have you ever done anything like that? Has that been
No, I usually will palpate it intra-op, if you pass it, but that's a great idea.
So if I'm not in the stomach anyway, but I want to put the NG tube in, then I won't open the stomach for this purpose, but I'll still have them do it. And then through close palpation to the stomach, I'll grab the NG tube and then have them pull it out. But in that case, they won't suture it. They have to just literally just shimmy it through that eye here, and then I just unravel it by not opening the stomach, and they'll pull the orgasm tube out. And it's a cool way of having the NG tube in there already without any frustrations or annoyances afterwards. I don't have to go to radiology at all. I know where it is. Scrub nurse. So this is along the same lines as my spay comments of using a balfour retractor. We underestimate the use of having somebody in there helping you. As surgeons, we typically do get a bit more spoiled. We have a lot of people around us, and we have a dedicated person who is a scrub nurse. And that person's job is to keep the OR table organized. All the instruments are in place. They're also supposed to be listening for the surgeon for what instruments we need. That way we can focus on the operation and not even look up. We can just say, al situ forceps, boom, medicine bombs, boom, right? And now we're not looking up all the time, and that stuff takes up time. It also, over time, creates physical exhaustion for us. If you have the luxury of having somebody there who knows the instruments and they can hand them to you, it's great. They're useful for retraction, obviously, patching instruments, maintaining cleanliness. They can keep track of those bloody causes, making sure that they're throwing them out for you, so you can focus on the surgery. And then if you're performing procedures that require stabilizing the organs, then they help with that as well. You have to make sure that they're aware of sterility, of course, but typically if they are a dedicated scrub nurse, they're aware of this. Otherwise, if you don't have those options, balfour retractors and Gelpies. I've used plenty of large Gelpies as balfour retractors. And you can see in this picture here, there's a Gelpie, the cranial aspect and the caudal aspect of that patient being used to open up that abdominal cavity. So those are some pretty neat options as well. But you want the surgeon focused on the procedure, and if somebody can hand instruments to you, I don't care what you call the instruments. If everybody knows in that hospital you call a Gelpie a thingamabobber, fine. Doesn't matter. The point is not to have to look up every single time. They can just hand it to you and you just tell them what you want.
How many of you guys have the ability to have an assistant? A lot.
Yeah.
But I mean, is it like, could you get somebody to do it if you tried, or is it they don't want to, or you don't have the staff for it? Staffing? There's staffing issues in that thing?
Yeah, imagine that. Next slide.
Preoperative imaging is like super important, obviously. I think, this just needs to be done as part of your routine. You don't want to go in there blind. I think it's really easy to get pushed into doing, skipping on diagnostics for cost reasons for clients, but again, you don't want to get burned doing this. You don't want to take out your splenic. Your hemoabdomen really should have chest rads. Because what you really don't want to do is, forget post-op and then take an x-ray that looks like that, or the 2-week pre-check look like that. That dog probably shouldn't have gone to surgery, most likely. Clients would be upset. So make sure you, are doing the appropriate imaging. You can do it under anesthesia if it's a really bad patient, on the way to the operating room, so you don't forget. Try to get orthogonal rads. It's really, really helpful. There's so many examples of how when you don't get orthogonal rads, you kind of miss things. For cystolithiasis, I take rads every time. Even if I have one a week prior, I take it right before I go in the OR, because I've seen them move in a week into the urethra, and if you're not expecting that, you do your cystotomy, and then it doesn't pee, you send it home, and it blows out the cystotomy incision, and it's your abdomen. That sucks, especially if there was a stone in the urethra. So I always just take a single rad for that, right going in, and always take post-op rads once you're done too, and make sure you get that urethra in there. I've seen that be a problem multiple times. It's very preventable. So get your imaging that you need, and also for foreign bodies, oftentimes there's that questionable foreign body of is it truly an obstruction or not? You don't have access to an ultrasound, maybe, repeat a rad if it's been 12 hours before you're gonna do a surgery, or if you don't want to come in at night. I would repeat a rad because, it's not great to go in there and just find it in the rectum. It's great because you can just squeeze it out, but maybe you didn't need to go into that surgery after all. Also for tube placements, if you're not going to palpate like an NG tube, make sure you're taking a radiograph to document these things, and E-tubes. I've seen plenty of cats that We're getting, what I call a pseudothorax or pseudomediastinum, because the tube dissected between planes and not actually in the esophagus. They're just dumping food into its mediastinal space, and it looks like it's in the esophagus. So just make sure you take the appropriate RADs for these things to kind of cover your ass, but just do the right thing. And again, looking out for metastatic disease and stones, I think are big reasons to do these.
Next slide. So with biopsy collection in general, and again, Justin, let me know if you do something different. If I have a negative explore, I'm going to biopsy, and at minimum, it's going to be stomach, jejunum, pancreas, lymph node, liver. Do you have sort of the same list of organs that you're looking for? If you're doing
Yeah, I do to like an extent. I mean, I think that's a good topic, because for the acute vomiting dog that has no symptoms that we took to surgery, I don't always biopsy everything, because I'm like, it probably was a dietary indiscretion. I don't know if that's the right thing to do or not, but I also feel like it's not 100% benign to biopsy an organ that could leak. But for something chronically vomiting, yeah, it's negative, absolutely biopsying it and all that. So
yeah, I don't know the answer either.
Yeah.
I mean, a lot of these cases of acute vomiting and diarrhea, you take to surgery because you thought you saw a foreign body, or there was something concerning on the radiographs that appeared cervical. A lot of these come back as basically inflammatory bowel disease on their biopsy results and the histopath. And well, that patient just had like a day or two worth of clinical signs. It wasn't some chronic enteropathy. So is this really IBD, or are they interpreting it that way, but it's really just a dietary discussion? Sometimes biopsying it becomes a bit too much information, because now you have to deal with it. They have to deal with the results of those histopaths. And there's abnormalities there. There are white blood cells accumulating on histo, and you have to deal with it. And the patient's already getting better without any IBD therapy. So it can be really good, because you can find stuff that you would have missed otherwise. It can also be pretty bad, because you have to actually interpret those and deal with those results. So you want to make it based on history, clinical signs, or diagnostics. Let's say, for example, I have a routine cystotomy that shows up, and we're going to operate on that pet that day, but also had a day of vomiting too. It doesn't always make sense with cystotomy, although you can make an argument for that. But I would probably talk to the owners while we're in there. Acute vomiting, we know there's bladder stones there, they may not be related. Do you want us biopsying GI tract if the abdominal sportoid is otherwise normal? And let the client decide if they want that. God forbid you do a cystotomy, and then a week later those clinical signs of vomiting continue, and someone else takes them to surgery, finally got lymphoma this entire time. That's unfortunate. You're already in the abdomen. You didn't give the clients the option. They can decline the option, but you offered it. So that's what I mean when you base it on these clinical signs and history as well. Next slide.
And then, again, when you're doing the surgery, I think it's really, 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 really important to be in contact with your anesthetist, whether it's an anesthesiologist, a technician, a friend, uncle, whoever it is that's doing it. Be talking to them, let them know, because if they're seeing changes on that monitor, they're also going to want to know too, why did the heart rate go up all of a sudden, why did the blood pressure drop, right? Is there bleeding going on? So if I have a bleeder or something, I'm going to tell them, I just hit a bleeder, we just lost a moderate amount of blood. They don't want to find out 20 minutes later after they've been pressors and all this stuff when they really needed to give it a fluid bolus or blood. So be in communication, tell them what's going on, tell them what you're receiving. When I'm taking out, adrenal tumors and I'm having to include the cava, I'm gonna probably tell them that I'm holding the cava off so they don't freak out when the pressure tanks. So be cognizant of what you're doing, and tell them what they're doing. Just be in constant communication. Look at your intestines. Sometimes you'll see the intestines kind of just change to cyanotic, and that can sometimes happen if they throw in a thrombus or something like that. So be aware of you're kind of interconnected with what you're doing there. If you're cutting and things aren't bleeding very well, maybe there's a problem with the blood pressure. They should be talking to you too. It's opposite. I know when the blood pressure's high sometimes because I'm trying to do something and it's what the fuck, this does not stop bleeding. What's going on? Oh, his blood pressure's 180. So check on those things. It kind of explains what's going on. And if you're seeing a lot of hemorrhage, again, this is when you gotta talk to your anesthetist and tell them maybe we should be looking for blood. What are you seeing up there? How's this patient doing? Also, their depth of anesthesia. Sometimes it looks fine up there, but that incision is so tight you can't do anything, and you're it's awake. They're it's not awake. I'm it's awake. So you gotta have that kind of conversation, to kind of work better as a team together.
Yeah, and then the point here about cardiac palpation to the diaphragm, it's a scenario where you're trying to figure out is the heart okay? And maybe you're not trusting your machines. Maybe your technician can't really hear the heart through the chest with the stethoscope. Well, you can look at the diaphragm, and Sure, you're not a human ECG, but you can at least look and say, okay, the heart is beating. Seems like a pretty good heart rate. I can count it, right? The contractions look pretty consistent. So at least there's that. You have that until you figure out the diagnostic tools that are not operating right in your OR. Next slide. So when I consider referral, so obviously this is going to be based on your previous experience, your training, what you're comfortable with, your clientele, what you have around you as far as referral availability. A lot of this comes into play, and client communication is always going to be vital. Just because you want to perform a surgery doesn't have to go to a surgeon. It just depends. It depends on all these factors. And by client communication, I mean going over with the client what you think the diagnosis is. It's surgical. Can you handle it or not? Or does the client have a preference? Do they want to go to a board certified surgeon and probably pay more, but also have the expertise? Or are they like, no, doc, I trust you. I understand this is your first cystotomy, but I can't afford their prices. I like you. I understand that there's different expertise. I want to stay with you. Great, fine. You spoke about it and you're willing to tackle it together. So the client communication is key. Does that mean that every procedure should be performed in that manner? No, you're probably not going to just go ahead and do an exploratory sternotomy on a patient in your hospital, right? Or do a ventral slot. There's going to be limitations to this, but the more common surgical procedures occur commonly, and so therefore, based on what your desires that the client wants, what they can do financially, and depending on their personality type and what's available to you, client communication is key. So there's a variety of different gastrointestinal, urinary, biliary surgeries that can be quite complex. And then let's also not forget the level of post-operative care. So if you're going to perform a procedure on like a bile-peritonitis case, or a septic abdomen, are you ready, able and willing to place Jackson Pratt drains? Are you able to, do you have pressors in your hospital for post-operative care? Are you willing to deal with the aftermath of a complex procedure? And it all comes down to what's available to the client, what's your comfort level, having that clear communication with the client before you venture into these procedures.
Yeah, I think this is a really common question that I think we get a lot of times is like when speaking is like, can I do this procedure? Do you think that I can do an anerotomy? I'm sure you can. But like, can I take out a gallbladder? The act of taking a gallbladder out isn't that challenging. You're cutting out a gallbladder. But my answer to people whenever they ask that is just kind of like, are you comfortable doing a cholecystoduodenostomy? And when they say, what is that? Then it's like, the question is, well, I don't know if you should do that. Like, what if you can't take out the gallbladder? What if it's obstructed? Then you got to close it back up, send it, or euthanize it. Maybe it didn't need to be euthanized. So it's really your level of comfort, and I think that it's a really interesting discussion because owners are vicious at pushing you to do what they want, and I think that they can really push people, including myself, into doing things that are uncomfortable. And as much as they're nice at that time, they're also very quick to turn on you when things go poorly. And I think this opens up a whole discussion that I actually enjoy because there's so many different levels of this. Because then it's like, okay, well, doc, I can't do a referral. Can you do this? Because I can't afford it. Do you really think that your time for doing a cholecystectomy is cheaper than mine? You guys should charge for your worth of what you're doing. It's a complicated surgery, and it's not something you should be doing for free. And then what if you do it and something goes wrong, the surgery goes fine, but then they got to spend $10,000 to keep the patient in recovery at a referral hospital? They're gonna come after you, for something because you're trying to help them out, and nobody is, it's just clients are like that. So you gotta take this with like a grain of salt. Like, whatever you're comfortable with, do it, but you gotta be prepared to deal with the complications that come with it. You gotta be prepared to deal with the post-op care. Like I've had people call me and say, hey, I'm in a septic abdomen right now. What do I do? I'm like, well, I mean, how's the pressure? We're not monitoring pressure right now. Well, that's step one. 2, like, can you close it up and put a drain in and send it over? We don't have any drains here. Okay, well, this is getting fucked really quickly, so I don't know what to do. So, but it's a situation you didn't really need to be in if your pre-op diagnostics are gonna know that this patient is septic. So kind of just, I guess my take home for this is like, I don't have the answer to what you should or shouldn't be doing. And I think that everyone's really capable of doing a lot of things. It's just a matter of like, what willing to deal with and how much liability you want to take if it goes wrong. and it didn't have to, if that makes sense.
Those of you who are hiring new graduates probably know this. We've gone the other way where everything is getting referred. Everything. And if you're the owner of the practice and you find out one of your new associates now sent over a diabetes case to an internist, you're not going to be happy with that. We treat diabetics here. Why would you refer that case? Oh, I was taught that you should refer these to the specialist. That's not a good system either. So you have to balance these two worlds. And I'm seeing plenty of new grads coming out saying, no, if it's not preventative care, if it's not basic stuff, I'm sending it. I'm sending it. They're barely doing workups. I'm sending it. Which that doesn't make any sense either. You should be able to at least go the route of working things up, labeling it a disease, and then figuring out from there, in conjunction with your colleagues and the client, what it is you want to do next for that case. But we are seeing a lot of referral, and so the other end of the spectrum isn't good either. Next slide. Oh, there we go.
That's fine.
Any questions? I think we have some time. Otherwise, I hope this was informative for you folks. Questions, comments, concerns? Okay, thank you.